Over to you, Abel.
All right. Yeah, thanks, Chika. Good morning, everyone. I'd like to welcome you all to the People AMR Network, and more specifically to today's webinar. My name's Abel Ekiri. I'm a veterinary epidemiologist based here at the University of Surrey within the School of Veterinary Medicine. One of the co-leads for the People AMR Network, and I will host today's webinar with support from our network manager, Chika, here, but also the rest of the network team that is participating in today's session. Let me just provide a few reminders about our webinar structure. It runs for an hour. We'll start with a brief intro for about 5 to 10 minutes, followed by the webinar itself for 30 minutes, and a discussion / Q&A for 20 minutes, and then wrap up. The webinar will be recorded, and if you want to ask questions, you can use the chat function, but also use the chat function to briefly introduce yourself. Remember to raise your hand when asking questions, and we can also look at the chat function for questions that are posted there. Before I welcome our speaker, I want to just provide a brief background to the AMR network. This is specifically to those who may be attending today's session for the first time. We've shared these slides before, and I'll try to run through them pretty quickly as a way of background. Let me see if I can find them now. Okay, you should be able to see the slides, Chika, correct? Can you see the slides, Chika?
Yes, I do. Sorry, I was
Okay.
on mute. My apologies.
No, that's okay. That's fine. All right. So just a quick reminder of the People AMR network. As you can see on the slide here, our main focus is developing, but also evaluating interventions that do promote appropriate antimicrobial usage, but more specifically within community contexts. And I have a few other slides that I'll run through, more specifically, maybe starting off with the leadership team for the network. It's as we can see on the slide here. The lead is Sarah Tolkien-Crine at the University of Oxford, and we have a few other co-leads, as you can see listed here. Gail Howard, there is Sue that replaced Alistair. This slide is a little old, so I will need to revise that. Myself, Abel. We have Wendy at the University of Manchester, and we have our network manager, Chika. Who are we targeting in this? Our targets, as indicated earlier, especially in our acronym as well, we are targeting the communities. And when we say communities, we are really referring to prescribers, including across the different sectors. That is the animal health sector, dentistry, pharmacy, but also general practice. And on the other side, we're interested in the users themselves, whether those be farmers or small animal, companion animal owners, but also the patients in different settings, whether it be homes or care homes. And we are taking an approach that involves co-creating, but also co-developing interventions that can lead to sustainable behavior change. And again, this is focusing heavily on the communities, that is the prescribers themselves, but also the end users within the different community contexts. And with this, we are using various approaches, and this is just simply an example here. We are doing this work across disciplines in a very transdisciplinary approach, but also we are integrating various approaches, and this just to mention a few, as you can see on this slide. And the targeted interventions where we are looking at behavior change vary across the board, depending on the setting of interest, from infection control to vaccines to biosecurity to communication and so on and so forth. The activities are broad, but briefly, they include knowledge exchanges, ECL training, as well as placements. And you might have seen a few announcements around this. Webinars such as this that we are having today, but also looking out for those joint relevant funding applications that we can work with the network members to pursue future grant funding. We continue to accept membership, and you can use this QR code if you're not yet a member to sign up. And there is also a link down here. And if you have questions, feel free to contact our project manager, Chika, with the email address that is shown at the very bottom of this slide. Now, coming back to today's session, I'll read a brief bio of Helen, and thereafter I will invite Helen to start the talk. I'm delighted to welcome Dr. Helen Higgins, who's Deputy Head of the Department of Livestock and One Health at the University of Liverpool. And briefly, Dr. Helen Higgins is a farm veterinarian, a specialist in cattle health and production, whose research bridges veterinary medicine, behavior science, and epidemiology. Her work uses implementation science to uncover why evidence-based practices succeed or fail on farms, and to determine how vets and farmers can be better supported in making lasting changes. With expertise spanning behavior change and microbial stewardship and the design of practical intervention for real-world farm settings, Dr. Higgins brings deep insight into the complex factors driving antimicrobial resistance in animal health. And in today's session, Dr. Higgins will explore the challenges of improving practice in livestock systems, the behavior and structural barriers that shape antibiotic use, and the opportunities implementation science offers to create meaningful and lasting change. I'll now hand over to our speaker, Helen. I'll also stop sharing so that Helen can share her slides.
Brilliant. Thank you so much for that introduction. That was fantastic. And thanks for inviting me to give this talk today. So yeah, I'll just start showing my slides. Brilliant. Can you see that okay?
Yes.
Yes.
Fantastic. Just get my pointer as well. I love a pointer. Also, I apologise in advance because I have got a bit of an ear infection. So if you've got any questions, please do pipe up, but you might have to speak a little bit louder than normal. I'm quite happy to take questions as we go along. So you're welcome to interrupt me, or if you want to wait till the end, that's equally fine. Brilliant. So we'll crack on. Has that moved on for you all? The next slide.
Yes.
Yeah, brilliant. So just to set the scene, in terms of implementation science, for those who are not familiar, people often talk about the three levers. So we've got obviously the evidence-based thing itself, which for different people will be different things. For you, it might be your new brand shiny guidelines, or it might be a new diagnostic test or some other intervention that you've probably spent a long time proving is evidence-based and effective. And fundamentally, we want to design that so it's as easy as possible to use given the context, I think. We've also got the context itself, and people will often do a lot of work trying to identify the barriers to implementing the evidence-based thing in that specific context. And then we might want to think about how we can map those barriers that we've identified to the various implementation strategies that could be available to us, and maybe to justify how to select what would be the best strategies, and potentially look at how does the context influence whether some of those strategies work better than others. And then obviously underpinning all of that, we've got these TMFs, the theories, models and frameworks, the science, if you like, behind all of it, and the design methods, which is hopefully going to help us to do all of this stuff and do it brilliantly. So for this talk, I'm going to mainly talk about an evidence-based thing that we've been trying to design so it is as implementable as possible. But first, I'm just going to set the scene a little bit with one slide, just looking at maybe some of the bigger picture challenges of tackling AMR in livestock, which is my kind of health setting, versus other human health contexts. I'm very much thinking about the UK here. So this slide's by no means meant to be exhaustive, but I've just picked out maybe some of the big issues here. And I think the key thing is there are differences, fundamental differences, but there also are quite a lot of similarities. So, for example, I am very jealous of the NHS. Free healthcare at the point of delivery in the UK is massive, I think, in terms of some of the challenges, albeit with the problems it has. That is still a huge difference compared to livestock. And obviously, you've got an awful lot of national guidelines. In a centralized way, which we don't have in the same way, which is obviously not to say that, you know, I know because I've done work with some doctors to say that doctors don't always follow the guidelines, and they knowingly don't follow the guidelines, but nevertheless I feel like some guidelines are better than no guidelines. And also you'll be dealing with individual animals. Obviously, in my world of livestock in particular, farmers must pay for everything. And that is different actually to companion animals, where if you've got owners that are financially struggling or on benefits in the UK, there are large animal charities like the PDSA, where they can go there for free veterinary care or very reduced cost veterinary care. That's not true for dairy for farmers. They have to pay for all, if they want to get diagnosis, they've got to pay for all the imaging, all the diagnostic tests, they've got to pay for the treatment, etc. So I've yet to meet a farmer that wants to actually spend money on antibiotics or antibiotics or whatever. They fundamentally don't want their animals to be sick to begin with, but it's a very different setting. Also, obviously, vets prescribe and can sometimes do supply antibiotics or other drugs, so there's tensions and conflicts of interest there. And certainly in livestock, I'm always dealing with groups of animals, so it's very rare I would have one individual animal. I'm dealing with groups of animals, and we've got withdrawal periods on the drugs, so these are animals going for food, and so there are issues around we can't have antibiotics, for example, ending up in milk for human consumption. So these are some kind of really big differences, I think. But there's also a lot of similarities. So if you think about the diagnostics, we've got shared kind of challenges around slow turnaround times with getting results back from laboratories. We've got shared problems, whether you're a dentist, a doctor, a nurse, a vet, around the inconvenience or logistical challenges of getting the blood test in the first place, whether it's my mum who's got dementia and doesn't like going to the GP, or whether it's a bull that weighs in over a ton and is having a bad day and doesn't want his blood taken either. We've also got issues around our tests not having perfect sensitivity or specificity, for example. But generally speaking, I think it's fair to say we do have less rapid diagnostic tests available to us in livestock. And also because animals are valued, the value of animals is a lot lower to society. It's also the case that sometimes, obviously, we will post-mortem animals. We will slaughter them and sacrifice them just to get a diagnosis, which obviously you're not going to bump off a few people just to get a diagnosis in humans. There's also similarities, I think, shared challenges around complex decision making and managing the clinical uncertainty through prescribing drugs, and pressure on clinicians, whether you're a doctor, a dentist, or you're an animal keeper. I think it's fair to say that in terms of farm vets, there's potentially a bit more pressure on us in terms of the financial need to maintain good relationships with the farmer, because that one farmer may have 1,000 sheep or 2,000 head of cattle, and if we lose that client, that's going to have a massive impact on our own veterinary business, which is rather different. If you're an NHS consultant, if you upset one person by not prescribing antibiotics, then the impact on you financially is going to be significantly less. So some similarities, but some major differences. I say what I wanted to mainly talk to you about today was about some work we've done co-designing a rapid diagnostic test for use by UK sheep and cattle farmers. And this is very much a collaborative effort going back a long time, involving various kind of stakeholders. A lot of this was funded in terms of the BBSRC Research Council, but also AHDB, who are a farmer levy board, not for profit, a pharmaceutical company, and GADEX, who are sort of a global diagnostics company as well. So just a bit of background here. I'll be quick on the background, but this is about fascicola hepatica, which is a liver fluke infection in cattle and sheep. We have a lot of sheep actually in the UK, 30 million roughly, and about 10 million cattle. There's an intermediate host, which is a mud snail that likes warm and wet conditions. And that means that in terms of climate change, this is changing the picture in terms of the epidemiology and making predicting what's happening with the disease and kind of the infection pressures more challenging. There is only one drug that treats all stages of this infection, triclobendazole, and it would be the same drug that would be the first line choice in humans as it would in animals in that sense. It does kill sheep. Sheep like to die anyway, but we get acute, subacute and chronic infections in sheep. And so farmers are quite motivated to not have their sheep die on them. Traditionally in the UK, control has centred around the routine use en masse, so treating groups of animals or indeed the entire flock with drugs, typically with no diagnostic testing. If they're going to go down the diagnostic testing route, then the only options until recently were blood, which meant the farmer had to pay the vet to come out and take a blood sample, and also that the farmer had to gather the sheep off the hills or mountaintops. And if you've got 1,000 or 2,000 sheep, gathering them and bringing them in is no small task in terms of labour and time, or get feces samples and do kind of fecal egg counts. But again, you're still going to have to gather the sheep. Then you're going to have to wait days for those results to come back. You're not going to keep the sheep gathered. You're going to have to let them go back onto the hilltops or mountainsides. And then if the results come back positive, you're going to have to bring all the sheep back in order to treat them. So the whole inconvenience and logistical challenges around that is not trivial by any means. Because of this extensive use of drugs over a long time, inevitably we now have widespread resistance, which is increasing, and this is internationally as well. So required clearly urgently a new rapid diagnostic test and human behaviour change to testing before you treat, rather than traditionally what has been done, certainly in this country, which is testing at very fixed times of year, which, because of the changing epidemiology, is actually not necessarily the right thing to do anyway. Fortunately, scientists at the University of Liverpool, going back over a decade now, so starting in 2014 with Tess Walsh's PhD, led by Professor Dinah Williams, who's quite a well-renowned, well-respected parasitologist, veterinary parasitologist. She recently retired. There she is in the background on a sheep farm. Have been developing a new lateral flow test, which is a point of care rapid test, gives you a result in a few minutes, aimed at detecting circulating antibodies for liver fluke. The original idea for this came from engagement with farmers. So it's very much kind of a bottom-up approach. And this slide is really summarising an awful lot of work that's gone on over that decade since, in terms of multiple grants, mainly from BBSRC, in terms of improving the design, validating the test on a lot of farms in Scotland, England and Wales, so a lot of trials, and also some social science research in terms of market surveys and focus groups. Farmers have had a significant amount of input right from the get-go with this, and their feedback has been crucial without. It's very much also been an iterative process. So if you like, kind of co-design right from the beginning, and not just farmers, to be fair, also other stakeholders, vets, private vets in practice, and also SQPs, suitably qualified people who can prescribe these anthelmintics, as well as vets. So a lot of work. I was not involved, importantly, with any of this. These are all very clever scientists, not me, who've done all of this work, and I don't do this sort of work. But it was all, very, very hard work and very well done. The aims with this was very much that the farmer would be able to use the test unaided, so without any kind of veterinary involvement or other advisors. And there are multiple advantages to that from their perspective in terms of cost savings, not having to get the vet out, helping them to, really have ownership and understanding of the epidemiology and what's going on their farms. Big advantages, obviously, in terms of convenience and practicalities I've just mentioned. And very much, I think Diana and her group felt that because actually the pandemic would help us here in terms of them using this test, because they would have familiarity, because it's a similar type of test that you would have done with through the pandemic with the COVID testing. I came to this party quite late, and I have to say, I had quite a lot of concerns about this in reality. I think partly because of my background, I spent over 10 years in private sort of farm practice, working day in, day out with farmers. And I just know, and I'm also quite old, and I know of many veterinary interventions that you think at the time are brilliant and they would fly and everybody would just adopt it into routine practice, and they have either crashed and burnt or just not been taken up. I also thought, the execution of this test is actually a bit more complicated than a COVID test. It requires them getting blood out of the animal, which traditionally is seen as a veterinary job and difficult. I also know about the huge variation between farms and the conditions on those farms. So farmers are a very diverse group of people. They're incredibly entrepreneurial, go-getting farmers. There are people who are very strong scientific backgrounds who are farmers, who've got PhDs, etc., really into surveillance, really into diagnostics, and other farmers who are just, not so much into that stuff. Also different conditions and just, availability of labour and financial circumstances of different farms. So that, that was a concern for me. And then also when I looked to the human fields and rapid diagnostic tests to say you've got a lot more than us in livestock, it's really clear that even when, maybe these tests are free at the point of delivery, that they're not used sometimes at all or adopted into routine practice, or they are misused. So, the test comes back negative and people test anyway, for example. So they're used, not used, and also misused. And so that experience was also making me feel a bit concerned about this. So we were very fortunate. I was very fortunate to work with Diana, and we won another BBSRC grant just before this test was about to be launched onto the UK market. And my kind of work packages were all around trying to preempt issues and to really evaluate the usability of what was now a near final prototype of this liver fluke lateral flow test. And very much where I was coming from, this was about focusing on the user experience, and in terms of Proctor's implementation outcomes, it was all about the feasibility and the fidelity. So how easy is it in reality for farmers to do this by themselves? So all the work up to this point, Diana or a member of her research team had been on the farms with the farmers and their vets, showing them what to do and working out, was it technically feasible, but they hadn't been left to their own devices with the test. And ultimately to use the results to inform sort of the design, because we were pre-design freeze at this point, so there were still chances to change things, and also maybe the training and communication strategies in the future. So in terms of methods, phase 1 was about, doing the usability testing. This was non-random sampling. We went after a range of kind of experience in terms of the sheep farmers, how long they've been farming, ages and attitudes. I was very keen to include what I call the seldom seen farmers. So not the keen beans, not the, really entrepreneurial, proactive farmers, but maybe the farmers that be a bit less skeptical, more hesitant about adopting this themselves, and clearly not used in previous farmers that had not been involved in all of the previous trials, which had been done quite a lot. So we wanted them farmers that had never seen this before. We asked farmers to test 10 sheep and to do that unaided. And this is what they got given. So this is obviously before it's actually been branded, etc. So they just got basically this box with the 5 lateral flow devices in it, 5 lancets to get the blood, 5 little sample pots to put the blood in, a little collection device to collect the blood, that's the chafed buffer solution to make it work, a reference card so they can interpret the results, and then the instructions, which at this point that's all there was. There was just written instructions, which is quite text heavy. So that's what it looked like kind of schematically. And one of my concerns about this was these little bottles, quite fiddly, potentially getting blown over in the wind if we're doing this outside. And also with the collection cup, they had to get a very precise amount of blood out of the sheep. So they had to fill this little cup to just the right amount. And that was actually really important. So what the farmers had to do, they had to stab the sheep in the ear or its nose, their choice. If they had a very woolly ear, they might want to go for the nose. Collect the blood with the cup, transfer that into the sample bottle and mix it up, and then put 1 drop into port A, and then use the chase bottle to put 3 extra drops into port B. And then if they got a control line, it meant they could then read the test and compare it to the reference card. So if it was 3 or above, it was positive, and otherwise it was negative for exposure to liver fluke. So that was the task. We went down the Think Aloud methodology, and I was very much influenced by Professor Lauren Clack with this, because she inspired me with a lecture where she was saying this was a great methodology if you want to observe and record human behaviour, which I absolutely did. I wanted to know, in terms of what people are actually doing, how do they find this test? And video recording was really critical here. So I did say Alison Howell was the fabulous postdoc who did actually do all the hard work, but I suggested she audio recorded it, but only as a backup in case her mobile phone, the video recording failed. The video recording was really critical. So with Think Aloud, if you're not familiar, people do the task, but they also say out loud how they're finding it and what's going through their heads at the same time. So it's really, really helpful. We got Alison to give a demonstration first with a COVID test kit, because it's kind of similar but sufficiently different that they'd get the idea as to what was required. And then we having recorded it all, me and Alison independently kind of went through the videos and analysed it to identify any errors or health and safety concerns, be that with the animals themselves. And you can see here a farmer getting the blood out of the sheep's ear with the little collection device. He's got other sheep milling around. Or with health and safety concerns with the animal or with the farmers. Because one of my other concerns was if they couldn't get the blood, they might just get the penknives out and start, hacking at the sheep with their penknives, which farmers often carry. And even at the very get-go, would they, for example, be able to get the top off the lancet to use it, for example? Turns out no, they couldn't. So that's what we did. We characterised the issues in terms of the frequency, severity, and persistence. And then having done that, we fed that back to the manufacturer, and then in the hope they might make some changes if needed. And then the test launched onto the market in the autumn of the same year. And then we went back. I didn't know we were going to do this, but we did. We went back and we repeated the testing with the commercially available kit and guidance after it launched. So in terms of results, we went to, in the end, 6 sheep farms in Cumbria in sort of the winter. The conditions on that farm varied considerably. Some farms did it in a barn. It was undercover. There was good lighting and there was a table. Other farms were doing it completely outdoors, and that's them putting the test box with the instructions on a dry stone wall. That's the only flat surface they got. It's actually a bit wonky to put the stuff on. Others were doing it on upturned buckets, fence posts, or kind of straight straw bales, stuff like that. You can see here we've got straw bale. We've got a bit of a don't know what that is, bit of a post, bit of to put the stuff on. And our little pots here, obviously, they're flopping around here, not standing up straight, etc. In terms of 1 or 2 people involved, some people did it by themselves, some people did it in pairs. The videos, I have to say, are some of the most entertaining videos I've ever watched in my life. It's better than EastEnders. Hilarious watching them, I hate to say, struggle with doing this test and some of the mistakes they made. Some of them realised they were doing mistakes as they were doing it, and some of them didn't, which is important to understand. 2 out of the 6 farms were completely unable to do the test without help. We very much said to them, we're just here as a fly on the wall. We're not here to help. We're only going to step in if you really can't do it. And 2 of them just couldn't do it. Mainly this was around the lancet. Even they just didn't understand, completely confused as to how it worked. Didn't even know they had to get the lid, the top off. concerns about how big a hole it would make in the sheep, would they hurt themselves, etc. Really just didn't understand. It didn't look like the picture in the instructions. Once they had some help, farmers were able to complete the subsequent tests. We had 32 errors in total that we observed. 17 of them were in the most severe categories as we define them, which basically meant it prevented them from actually getting a test successfully completed. The main issues other than the lancet, which were significant, were just not reading the instructions at all, or only, sort of halfway through, or just not understanding them, or not having their glasses because it was quite small text. Not waiting long enough for the blood to come out, and either under or overfilling that little blood collection cup. And as I say, the precise amount was actually really important. And then also issues in terms of interpretation. So as I say, hopefully they would have got a control line, although they didn't all. And then a test line, and they had to compare it to the reference card. And there was some confusion over doing that. He also asked them to score their overall experience in terms of the usability and user-friendliness. And interestingly, they were very positive, I feel, in terms of the scores. So only one farm scored it okay. The other farms were scoring it either good or excellent, despite all of these issues that they were having. And that's actually quite a well-recognised phenomenon, that if you ask people to rate their experiences overall in terms of usability testing, they often do score it a lot better than the reality of what's actually gone on and actually how much they have in fact struggled. Sometimes not knowingly struggled because just haven't realised they've been doing things wrong. So following that, we fed it back to the manufacturers, and they did revise the instructions. They had more pictures and less and bigger text. They also, and this was a key suggestion, was they created a video. And on the instructions, they then included a QR code to the video, which was quite short, but went through how to do it. Also, they included 2 to 3 extra spare lancets in the box, because because these were single-use lancets, if they failed to get blood or the lancet went off, they couldn't actually then use the test on all 5 sheep at all. The manufacturer also made the decision that these test kits would only initially be sold via vets, which was different to the original plan, was that they would be available via other merchants, so agricultural merchants. And that was not just as a result of this usability testing. We also did quite a significant amount of focus groups throughout the UK with farmers, dairy, beef, sheep farmers, vets and SQPs. And the feedback from that also kind of fed into this decision that they were going to only release this via vets on the basis that it would hopefully give farmers better access in terms of trying to interpret what the results meant and retesting. Important to say, not all of the recommendations we made were actioned. I'm not sure at this point I'm actually allowed to I've got 100% approval to disclose all the things that were not actioned. So in the interests of staying on the safe side, I'm not going to go through all of that, but not everything. A lot of things were, but not absolutely everything. The manufacturer also kind of unilaterally changed to a different brand of safety lancet, which was not based on our recommendations, but was they did that for manufacturing purposes. It was similar, but it was a different brand. That's just to show you. So those were the instructions before, and then this was after phase 1, and I say you've got the QR code there. So we then went back sort of post the commercial launch, and we did it again with what is now the actual available kit. And this was 5 different farms now in the Yorkshire Dales, and it was sort of late autumn going into winter. There were now, when we did, it was exactly the same methods. There were now 23 errors. So it was kind of a 30% reduction in the number of errors, but there were still 10 in the most severe categories, meaning that they couldn't actually complete the test successfully. There were still major issues with under and overfilling the blood collection cup. And I think one thing to mention here is that the weather conditions were quite different when we went back the second time. It was now below freezing in all cases. And I think part of they did have quite a lot of issues with getting the blood. That may be to do with peripheral vasoconstriction of the animal's ears and resulting in kind of poor peripheral circulation. So that may have been a factor. The other thing I think is that when they did manage to get blood, I think the farmers were often so delighted they managed to get blood out of the sheep that they would thought that their mindset was the more the merrier. So, scoop up as much blood as possible. But obviously, as I say, that's actually, from our perspective, not what you're supposed to be doing. But they didn't, they didn't understand that the importance of just getting the exact amount. No farmers used the video initially. And that was either because they were unfamiliar with QR codes, just didn't know what they were and hadn't used them. They didn't have a suitable smartphone to be able to get the QR codes, or they didn't see the QR codes on the instructions. So they just missed it on the instructions. And again, there were 2 farms that got so stuck, they just could not progress. And so the researcher, Alison, had to step in and point out that there was this QR code should they wish to use it. And if necessary, actually show them the video if they couldn't actually access it. So that was important to appreciate. So in terms of conclusions from that kind of work overall, I would say there were a number of major issues when using this lateral flow test by untrained farmers who had never seen it before. But some of the errors, I say, were obvious. If they just tipped the whole of the little green, if they took the whole lid off the green sample pot and poured it over the lateral flow device, it was obvious they realised themselves that they'd done it wrong. But some of the issues they didn't realise, and that could potentially lead to persistently incorrect results if they carried on doing that. There were some unexpected issues, despite the fact that farmers had been involved in this, as I say, from the very get-go. Farmers have been involved with giving feedback to Dana and her research team, but despite that, there were new issues that hadn't been foreseen. Quite a few problems were mitigated by changes to the kit and to the guidance, but not all of the issues, I say, we identified were actioned, as it turned out, or at least not yet. They may well change things in the future. And so our recommendation at this point is obviously that training and support is advisable before first use, and to prevent frustration from the farmers who, as I say, ultimately are having to pay for this test. And the results from our focus group work was obviously that the perceptions were the test is expensive. And also to avoid erroneous results and wasted tests, which also would be expensive and confusing, potentially resulting in bad decisions being made, and then obviously potentially animals dying that don't need to. In terms of some challenges and I guess lessons that I personally have learned from this, quite a few. I'm glad we did it. I think Think Aloud testing was incredibly useful in this health setting. It's often done, historically it's been done more for things like product testing and for things like involving software or computer related kind of context, but it was incredibly useful on a farm, getting blood out of animals, and relatively inexpensive to some other sorts of tests that you can do. There is major variability, and I kind of knew that to begin with, but in the context in which the rapid diagnostic test will be used, out on the farms in the communities, and that is obviously important to understand. It's going to be easier if it's not raining or snowing, if it's not really windy, if you're indoors and you've got good lighting and you've got a table, it's going to be easier. Involving the end users from the start is great, but you still need to do repeated usability testing, and it's got to be completely real life. It's not real life if there's a researcher there showing them and helping them, because that's not the reality of what would happen. I think the Think Aloud testing and the usability, user-centered design evaluation, it's helping to put the human needs, behaviours and capabilities at the heart of that design process, making it as easy to implement as possible from the very get-go. And the end user experience is very important, especially, as I say, when those people are having to pay for it and live with the consequences if they make the wrong decisions and have dead animals. Other things I'd say is obviously it's potentially disruptive to normal workflows, asking farmers to, get blood out of the sheep for the first time and think aloud while they're doing it, and they're being videoed, is not it's not exactly real life because there is somebody there, and it's potentially, you know, more cognitive load because they're going to have to, you know, do the task they've never done and tell you out loud what they're thinking. So there is that kind of limitation, and it's worth bearing in mind the extra issues there. I would say try and allow a bit of extra time potentially to get ethical approval. Obviously you're going to have to get ethics for it, but because, not least because of those issues, it's worth thinking about. I'd certainly consider using user-centered design in other aspects of implementation science, such as, you know, if we're thinking going forwards about what other implementation strategies could we put in place to help the uptake and use of certain evidence-based interventions, to, you know, to use this in that context. And I think working with multiple stakeholders, not just in this for this grant, but in other grants we've got, where we've got even, you know, quite a lot more stakeholders. All of our kind of relationship is and meetings are done online, and that's obviously very convenient and time efficient and good for the environment in terms of, you know, plane and petrol, etc. But I am increasingly moving towards thinking, should we be costing in for in-person meetings and extra time in order to help to really cement and develop those relationships? I'm interested to hear what other people think about working with multiple stakeholders as well. And finally, just to say a huge thanks to everybody who's involved in this. So it's a lot of people. I came quite late to the party, but a lot of hard research from very good scientists going back a very long time. A wide range of people, and BBC, HDB, Norbrook, GADEX, all the farmers and vets who took part, and the SQPs who are kind of anonymous, but all these wonderful people as well. So yeah, just to say thank you very much for listening, and very happy to take any questions or comments. I'll stop sharing.
Yes, thanks a lot, Helen, for a very insightful talk. I see some comments already in the chat window. I think we can take some of these. Let me see if I can go to the very first one here. But also feel free to raise your hand as we start off with the ones that I can see in the chat window here. I think one is from Dominic. Dominic, if you're on, if you would rather just say it out, you could do that as well.
Okay, yeah, thanks. Yeah, sorry, I guess this is something of a distinction that I've raised in the comment, which is, you know, measuring whether a technology actually works rather than the behaviorals around it, if it actually does work technically, which are two slightly different things. I guess diagnostics are a good case in point, because diagnostics can be used in different contexts, and people start to behave strategically depending on what they think the diagnostic is for and who's providing it and how much it costs. So I guess, yeah, it's a distinction that we're trying to make in the Impact AMR network, is when you prioritize an intervention, you know, you assume first that it works technically, and what you've described a lot of in the talk, which was fascinating, by the way, was, yeah, it might not work well here because of this and that and the other. And, you know, that's a kind of a technical issue rather than, okay, it works in most contexts, but people start to act strategically once you put it in to their production context, which is, you know, who's the information for, you know, when do I have to provide it? When will it be used? Who owns it? How much does it cost even? And what are my strategic incentives to comply with it, with the outcome? Those are kind of different. I mean, I suppose they're not ones you advertise that you're going to look at, but I suppose given that you're a behavioral network, that's a distinction that is worth bearing in mind. Cheers.
Yeah, definitely. And I think we did do we did focus groups across the UK, so including Northern Ireland, with dairy farmers, beef farmers, sheep farmers, vets in private practice, and SQPs, and a lot of that was looking at you know, what you're talking about in terms of I guess what the barriers they would see. And you know, there was a lot of I haven't presented that because kind of in the time to go through all of that would be whole talk in itself. But yeah, in terms of the, we got their views there on where it should be priced in the market, and all those other myriad of kind of factors that would play into whether or not they would be prepared to use it. So yeah, so there is all of that as well, but I say it was a bit too much to put into one talk, unfortunately. But certainly, inevitably farmers want it to be as cheap as possible, and there are economies of scale. So because they need, the statistics that Helen Clough, who's a brilliant statistician, did suggest they need to test a minimum of 10 sheep per group. So some of the issues around how many different management groups do they have, with different, if they're grazing on different land with different risk factors, so depending on their enterprise and how they're managing their animals, it could be more or less cost effective, if you see what I mean. So yeah, there's an awful lot more to it than just what we did with the usability testing.
Interesting. Thanks, Helen. Let's see, Sarah, if you want to go next.
Hi, Helen. Thanks. That was a really great talk and a really nice example of showing what humans can do when you give them a new piece of tech. And we see similar things in the human healthcare side sometimes as well. I think people assume that people are going to follow instructions and do things and see QR codes, which have been strategically placed at the top of documents, but obviously they don't. And it's nice to kind of pick up that detail. Building on from Dominic's comments, I'm interested in what farmers thought of the results when they got them, if they managed to get the result. Do they believe the results? Are they kind of willing to act on them? I'm interested in the fact that you had a scale from 0 to 10, and I think you said if it was 3 and above, then the animal would need treatment. I'm wondering why the test wasn't a kind of yes/no answer rather than a scale.
Yeah, absolutely. So I think just taking the second one first, the reference card was something that we, having said about feeding back, but yeah, I think one of our comments within this group was that I was worried they would overinterpret it, so that 10 was somehow you should treat more important to treat than, let's say, 5, and that's not how it works, and that was an important misconception. That was basically something that we fed back, that it should essentially be a yes/no, and that would simplify it, but ultimately wasn't, and they should change that, but ultimately wasn't. We are another piece of work, which again I didn't have time to mention, but we're developing a phone app so they can just scan the lateral flow device, and it will tell them in a whole sort of decision support tool around them what they should do, which that's sort of work in progress. So yes, so you're absolutely right. I think that was and when a really important thing that as it stands at the moment hasn't been actioned. Sorry, what was the first question? Was
it's whether farmers believe the results.
Oh yeah, absolutely. Yeah, sorry, yeah. So we went through that particularly in the focus groups actually, and as well, because that was about 50 people, so it's sort of slightly larger numbers. But the general feeling was, if we're going to spend that much money on the test, we will believe the results. Because otherwise we're not going to buy it. We're not going to, if we're going to invest, £100 a box, there is no way we're not going to follow what that, because, one of their issues is if they test before, some of them see it as a waste, because if they're going to end up treating anyway, why pay to test to get a positive? So I think generally the feeling for that was, if we're paying for it, we will do what the test says, was the general feel on it.
I'm just wondering if they've paid £100 and they're getting a 0 or 1, and they're noticing there's something wrong with their animals, whether they're going to be unsatisfied with the 0 or 1 answer and then go on to treat anyway. But yeah, interesting to hear.
Absolutely. And I think the other thing we've done from that work is saying that as well, that or from the vet side, is that everything is kind of blamed on liver fluke, but actually it turns out it isn't. And so that, you know, part of what you're paying for is the knowledge about where is your farm in terms of, you know, what's going on, and trying to get that message across about what you're actually buying with that test is, you know, the more holistic epidemiology, and being able to track that over time and trying to get that message across. You know, you're buying information and knowledge that you can then use, and building up a history, and not just working in the dark over it. Yeah.
Interesting. Yeah. Okay. I think Sarah, you have your hand up as well.
Thanks, Abel. Yeah, I do. But I noticed there's another comment from Matt first in the chat. I don't know if Matt's still on the call. Yeah. Hello, Helen.
Hi,
for those who
Sarah.
don't know, Helen was one of my she was an excellent veterinary supervisor for my PhD. So it's really interesting to hear the work you're involved in. It was a great talk, Helen. And just, hear more about the stuff that I am not involved in at all. I just wanted to add, one of your last comments was around the challenge of working with multiple different stakeholders in different locations, and if people have, oh sorry Matt, you are there, sorry. Just in the chat. Yeah, your question around, you know, views and comments on trying to get people together, and in, you know, our climate changing world, the challenge of balancing the kind of travel related emissions versus the value of getting people together in person. And that's something, so the project I'm involved in right now is a climate change project, an environment project. And we have exactly these conversations. We get a lot of pushback, both internally and externally, from people saying you shouldn't be flying internationally for conferences, or you shouldn't be flying from, say, Glasgow to Southampton or whatever, and trains. And I guess it's to say that, I mean, certainly the approach we've taken is that there's never one right answer, but there's so much value in face-to-face meetings, and that having, you know, maybe when we put together, you know, our 3 or our 5 year proposals, and we sort of say let's do lots of virtual meetings, they're valuable, but it's always good to have in-person stuff right at the beginning maybe. So yeah, it was just to kind of say, I hear that struggle, there's no easy answer, but equally having no face-to-face meetings. And also sometimes it helps, I think, as researchers, we tend to think, oh, we've got university, we've got research buildings, we can use a meeting room for free, we'll get everyone to come to the university. And actually, I mean, certainly for like farmers and vets, that's not necessarily viable anyway. But sometimes we need to flip it and think, how can we get to them? You know, maybe it's better to have meetings where people are as well, isn't it? That's another way of, because then also as research teams, we're perhaps maybe 2 or 3 people traveling. So even if we have to travel further distances, it might be less impact than getting 20 other external people to move around the country as well. So yeah, but no, it's good. It's a really interesting talk. Thank you.
Yeah.
No, thanks, Sarah. Yeah, and I definitely think probably definitely moving towards maybe, as you say, some strategic face-to-face meetings as a kind of compromise. Yeah, we had planned to do some meetings for farmers, you know, in a location that was, you know, say in the middle of Cumbria, which would be, you know, we could get all, you know, a group of farmers together in a relatively easy way. So just thinking about, yeah, what works for them as well, as you say. Yeah, it's really important.
And the word strategic, that, yeah, you're really right, like thinking about why you get people together. I'm about to go later this afternoon to our sort of annual project 2-day meeting, which was never, it's a 5-year project, it was never in our proposal. And because we're at multiple universities, we realized actually the core team need to get together from time to time and do things that aren't necessarily about work. So some of the next 2 days will be about work, but some of it will just be scheduled time to walk or do more fun activities where you just get to know each other, and because it helps build trust, right? You need to build trust between people, don't you? So yeah. Cool.
Yeah. No, thanks, Sarah. We have 2 comments here, Helen, in the chat window that I'll just read out. There's a comment from Philip, and goes, looks like the manufacturer should have visited a few sheep farms before developing their test. And there is also a question from Matt. I don't know, Matt, if you want to read that out yourself. If you're able to. If not, I can also read it out to Helen. Okay. I'll read it out, Matt. So the question, Helen, is there any scope for follow-up work to establish how consequential certain errors are? I imagine in COVID-19 pandemic, there were also a lot of non-ideal implementation of lateral flow assays. Note if similar work around how consequential errors were for this. And did you get pushback from academics or others who designed the test? As someone who came in late, I raised issues about implementation. And do you have any advice for navigating this successfully? I know we're running short on time, so Helen, I'll request that you perhaps try to rush through that response.
Yeah, definitely. No, and thanks for the questions. I think we definitely do need to do follow-up work, and maybe that was co-design. I've never really done co-production, but maybe yeah, that's another thing to look into. But yeah, I can feel another grant coming on in terms of, this is not the end by any means, sadly, it's only the beginning. And yeah, so I definitely think we need to look about how this is actually now being used and taken up. So another grant, I think, coming on there. In terms of just quickly pushback from that, I think that Professor Danny Williams was wonderful in being very open-minded about allowing me to come in on the grant, and I commend her for that. I do think I potentially sometimes come across a bit negative, even though I'm actually quite a positive person, but I'm just being realistic and honest about it. And actually, I think that's really, I do think it's an advantage actually if people are open-minded enough to academics say that they've spent a decade working on this. It's a lot of hard work, and then to have that other side of somebody that hasn't. I'm not wedded to this. I'm not invested in it in the same way. So to have people who are open-minded enough that they will be prepared to hear other people's views, I think is really, really hats off to Diana for being open-minded enough to do that and to work with me, and we get the grant. Yeah. But I also, in terms of, I think I then had to kind of, weave my way into that research group and work with people I haven't worked with before. And yeah, there are challenges there. I think, in terms of finding your way. And I think for me, I'm kind of quite into my coaching now. And so, those kind of maybe more advanced emotional intelligence, leadership, empathy things are quite important there in terms of teamwork and relationship building. But yeah, there is an element of you do absolutely have to I had to kind of integrate into that research group, and yeah, there are challenges. But I say for me personally, the coaching has really helped me getting a coaching qualification and developing those skills more, communication skills and coaching skills.
Yeah, no, certainly. Thanks a lot, Helen. Lots of knowledge exchange and cross-learning, certainly across the different sectors here. We'll cap it up, and but before doing so, Chika, do you want to announce the next webinar when it's due and who the speaker is before we wrap up?
Thank you everyone for coming for this session. We can't have this session without you, so we're grateful to have you join us. So the next webinar that we have will be 24th of February by 10 o'clock. I'll be sending around the invites shortly. It's going to be a very amazing speaker from Liverpool. So we're waiting for the last bit of information we need so we can create the flyers and then send around the invites. So we look forward to having all of you join. I don't have the title right now, so I can't really tell you what it is about, but I'm sure it's going to be very exciting and insightful as well. So thank you so very much. Thank you.
Yeah, thanks, Chika. And thanks again to our speaker, Helen, and to everyone for attending and contributing to the discussions at today's webinar. It was a pleasure to have you all. Have a good afternoon.